Yes, you are right, Dr. Hassan. First is ultrasound. Whenever we are suspecting stones, in cases of stones. So it is the first line to differentiate the focal parotid mass and identify the cellulitis. Okay, but still, whenever in the question they ask the best or the most appropriate thing, then CT will be the best because it is sensitive and 100%. Okay, no matter it's a contrast or non-contrast, both have same accuracy. You can go with the non-contrast. Am I audible now? No worries, Dr. MP. Hello, everyone. Am I audible clearly? Still sound breaking? No. Okay, good. So far we discussed about eosinophilic esophagitis. Those who have joined late, the first question was regarding eosinophilic esophagitis, and this is the second question regarding cellulithasis. So they are asking here the next investigation. Whenever they ask next or first time investigation, it is ultrasound. Okay. But if they are asking most appropriate or best investigation, that is CT, non-contrast CT. No need to give contrast. Both have same accuracy. Till then, read the question. Okay, read the question. There was a CT image. They have given you the diagnosis. But in exam, you have to diagnose from the image, the given CT image. Okay. So image shows rectus sheath hematoma. Patient had hit his abdomen to the table and then pain started. Vitals were blood pressure 112 by 80, pulse 80 beats per minute, hemoglobin 105 milligram per deciliter, and they're asking for the most appropriate management. What should be the most? Everyone, please answer quickly so that we can move forward. Dr. Jessica, IND is incision and drainage. So everyone, what's your answer? Okay, some are with abdominal pain and some are with IND. Let's move then. Can anyone tell me what is in the first image and what is in this second image? What is the diagnosis? Because they give you this sort of images and you have to diagnose from the image. Image number 1 and image number 2. How you will diagnose them? What is the diagnosis? Just with this CT. No idea. Okay. Anyone who has some sort of idea that? We are discussing. We are still discussing. I haven't both. Okay. Rectal hematoma. The first one is rectus. Exactly. Here is the rectus sheath. Okay. So this is the rectus sheath hematoma. It never crosses the midline. Okay, this is the midline. And this is the hematoma. Rectus sheath hematoma never crosses the midline. While retroperitoneal, these are kidneys. So you can easily see any collection behind the peritoneum. Our kidneys are retroperitoneal structure. So this is just close to the vertebra. Here it is shown in the pointer, but in exam you won't see this sort of pointer. But here you can see some collection, which is this collection has displaced this organ. Okay, so this is the retroperitoneal hematoma. If still you are, it would for you, it makes difficult to diagnose. Just see, whenever you found these eyelid bones and anterior, something that is anterior, think of rectus sheath. And in retroperitoneal hematoma, you found the cross section of ribs and definitely close to the vertebra on the back side. Okay, then it will be easy to diagnose. So the answer for our question was abdominal bend. Why? Because our patient was vitally stable. Okay, if our patient is vitally stable, we can just give them some compression, some sort of compression in the form of banding, and we need to observe them. Okay, if they remain vitally stable, then no need to evacuate in size or do any sort of embolization for the hematoma. So the first thing, if patient is vitally stable, just to compression, we can do with this abdominal band. Okay. If there is any abnormality in the coagulation profile, because most of the scenario, they give you a patient, old age patient who having atrial fibrillation and who are on warfarin or heparin for the long duration. And now just with a small hit, they got this sort of bleed. So that's why in those patients, if there is abnormal coagulation, just manage that. If patient is vitally unstable, then we have to like do fluid resuscitation or blood transfusion as needed. Okay, if the patient is completely hemodynamically unstable and the hematoma is expanding in size, okay, in that case, we go with angiography, like arterial embolization, or surgical evacuation of hematoma and ligation of that artery, which is bleeding. So this is the case when you have to look at the vitals of the patient. Like you have to see whether your patient is clinically stable or unstable. Only in that case, you will alter your treatment options. Okay. Next question is regarding schizophrenia. Man who has tried various antipsychotics is still having hallucinations and paranoia. He has tried risperidone, quetiapine. What to use now? So please, everyone, answer. Only one person. You answered. Hello. Okay. So what's your diagnosis here? Still my voice is not clear. So what's your diagnosis? It's drug-resistant schizophrenia. Okay, so answer would be clozapine. Okay, some patient when they are taking treatment, but still they have residual symptoms. Okay, whether they are clinically stable and adherent properly to their antipsychotic therapy, still they have residual symptoms. So in that case, we have to see the reasons first. That what are the reasons? Either they are adherent to their therapy or not. Okay, if they have issue with the monotherapy at adequate doses, we have to, like, they already taking one drug or two drug and still their symptoms are not resolving. In that case, the last resort for the treatment of schizophrenia is the clozapine. Why clozapine we don't give as the initial treatment? Yes, exactly. The main major side effect of the clozapine is the agranulocytosis and also weight gain, a lot of weight gain. That's why whenever we prescribe clozapine, we ask the patient for the regular BMI checkup, even monthly, and the fasting blood sugar and lipid profile that should be measured every 3 weeks. God, I don't know what's the matter could be. Just give me 1 second. Is it clear now? Hello, everyone. My voice is clear. Okay. So were discussing the treatment-resistant schizophrenia, and clozapine would never be the first-line drug because clozapine has a lot of side effects. So it is reserved for the patient who have treatment-resistant or drug-resistant schizophrenia. The main side effect is the clozapine, and because of that, any patient who is taking clozapine, the main side effect is agranulocytosis, and any patient who is taking, we ask them for the weekly blood count during the first 6 months of the treatment. So that is very important to ask the patient for the weekly full blood count. And also BMI should be measured monthly, and fasting blood sugar and lipid profile that need to be measured every 3 months. So you are clear with this? Let's move to the next question. 45-year-old women with the symptoms of depression, tired of her work environment, what could increase her risk of suicide? Family history of suicide, binge alcohol drinking, or sudden change of job? sorting out my voice issue. Till then, everyone.
My voice is clear now? I hope it would be clear now. Dr. MP, if ECT given in the stem for the previous question, ECT is the last resort. And indication for ECT is not the drug-resistant schizophrenia. Like if not responding to the drug, you will give ECT. If clozapine fails, then we will move towards ECT. And if in the question they mention like there is patient is not able to not eating well, or along with these symptoms, there is a tendency of suicide. In those cases, you will opt for the ECT. Other than that, if it's just drug resistant, go with the clozapine as a last resort. If clozapine fails, then you can go with the ECT. Okay. So for this question, we have to go through the SAT person criteria that is also present in the JM. As a SAT person, suicide assessing scale. That is very important. You need to go through that in a very good manner, because a lot of questions come with this. They just twist the scenario with the different variants. Sometimes they give you family history. Sometimes they give you personal history. Sometimes in the scenario they give you a hint of that patient has certain intents to go for the suicide. So you need to choose according to the weightage of that scale. Okay, that how many points are given for a respective variant in that scale. So some of you are saying B and some are with A. So I just put in the order, like if they mention previous like personal history of suicide, that is very important. It has 2 marks. Okay, 2 points. Family history of suicide is also an independent variant. Any mental illness like depression, severe depression, that has 2 scores. Substance abuse, intent to suicide, very strong. No support from family or community. Okay, so these are certain things that you just, if you can take a screenshot that you can take or just write it down. So that's very important while solving. Other than that, we have this SAT person index that is present in the JM as a table 10.1. Okay, whenever the score is more than 7, there is high risk of suicide. Okay, this is the mnemonic, and these are the variables. For major depression, it is 2. For psychosis or severe depression, it is again 2. For organized plan, like intent to suicide, it is 2. Okay. Chronic illness, no community backup, no support, 1. Okay. Alcohol drinking or other drugs, recreational drug use, 1. Previous attempt, 1. Okay. Age given along with or some of other things that will be important. So just make sure you go through this chart very well, and then most of your questions will be solved. For the previous question, the answer is family history, because nothing was mentioned as the previous history. Okay. Depression, they have mentioned, but they didn't give it in the option. If given in the option, depression will be the answer because previous mental illness like severe depression or major depression, it has 2 points. So for this question, we have answered with the family history of suicide. Okay, with the heat assessment, this is also a good chart, and it's the questionnaire related. You can go through when you will go through the PDF again. Okay. Next question is about a young man brought to ER by flatmate who found him drowsy with 3 packs of paracetamol. Okay, the recaller has mentioned somehow my memory tells me I calculate total dose as 15 gram at that point in exam. Okay, he has last seen him conscious 6 hours ago. He also had taken alcohol at a party before. Now he is in the ER. Vitals were all stable, including saturation, but he was drowsy. What is the most appropriate next management? Anyone answer? Yes, it's beyond 4 hours. Okay. Okay. So some of you are with C and some with C. Both are correct. Okay. But now we have to look at the scenario again. They mentioned vitals are stable. Okay. Last seen him conscious 6 hours ago. The first point. The dose is already like very high dose, more than 10 grams. So it's about 15 grams. The other thing, we don't know the time of ingestion. In STEM question, it is just mentioned that he was conscious 6 hours ago. We don't know when he took the paracetamol, 8 hours ago, 9 hours ago. We don't know about the time of ingestion. Okay, now vitally he is stable, but he is drowsy. In that case, would you wait for the paracetamol levels to come and then you start treatment? No. Ideally, this is the protocol. You need to measure paracetamol levels and ALT. Okay. But if your patient is drowsy, it's not alert, then this is the indication to start acetylcysteine infusion. Okay, this is a very good chart. If you go through this, it would be like, it will solve a lot of your questions with different time durations and with different scenario, what they are going to ask. Like if your patient presents in less than 2 hours, so with less than 2 hours, just give them activated charcoal. Okay, this activated charcoal is when the patient has taken immediate release or long release, but tablet form. Okay, not liquid preparation. In case of liquid preparation, we don't give activated charcoal. Then we have a window of 2 to 8 hours. Okay, in that case of 2 to 8 hours window, we have to measure paracetamol level concentration within the 4 to 8 hours of ingestion. Okay, he was conscious 6 hours before, but we don't know when he took that. Okay, after paracetamol concentration, like when it comes back, we plot that paracetamol concentration on nomogram. Okay, over nomogram treatment line. According to that, we commence or we start our acetylcysteine infusion. And then no investigation required. Just simple as that. If more than 8 hours has elapsed, okay, if more than 8 hours elapsed, what you will do? You will commence acetyl infusion. acetylcysteine infusion. In our question, he was conscious 6 hours before, but we don't know the time when he has ingested those tablets. So in that case, just start and then measure serum paracetamol concentration and ALT level. Okay. After returning of results, then you plot these paracetamol levels on the nomogram. Okay. If it's over the nomogram treatment line, we have to continue. If it's below, then we have to stop. Okay, Dr. Azhar, just try to understand that we have two things here. We have to take care of the time duration as well and the symptomatology of our patient. Here, we don't know about the time period, and the other thing, the patient is drowsy. He is not alert. In that case, you don't wait for this thing, like you don't wait for measurement of the levels. You have to start this N-acetylcysteine infusion. Okay, here again, over nomogram line, we have to continue the infusion that we have started. But if it's below the nomogram line, then we have to stop. And then again, we measure at the end of this infusion when ends, we measure ALT levels. Okay. Then ALT levels, if less than 15 units, then no further investigation required. But if it is more than 50 units per liter, then again, we have to continue and monitor. Okay. Just make sure you go through this chart very well. Your most of the questions will be solved. Okay, this chart is a bit blurred here. We'll go through the guidelines. From therapeutic guidelines, I have attached this chart, but it is a bit blurred. So you can see here, serum paracetamol concentration that is available 4 to 8 hours after the first injection. Then what you have to do, you have to start, like you have, if it's double, you have to start the treatment thing. I can't just mark it here. Let me open this pen. Okay. Here, if serum paracetamol concentration is not available within 8 hours of first injection or unknown time since first injection, as in our case, we have to start the standard dose. Okay. They have clearly mentioned, do not wait for serum paracetamol or ALT concentration. Don't wait. Just start the infusion, then stand. Okay. When results available, if concentration is below the treatment nomogram and first serum ALT concentration is lower than 50, in that case, we don't need to don't need to continue. We have to stop the infusion. That's what I'm trying to explain. Okay. But they are still saying if the serum paracetamol concentration is below treatment nomogram, but it was ingested within the 2 hours of blood being taken. In that case, again, we have to repeat 2 hours later, the ALT level. That should be below 50. Yes, here we don't know the one thing. And the other thing, our patient is symptomatic. He is drowsy. Whenever your patient is symptomatic, whether he is vitally stable or unstable, for instability, you have to just resuscitate the patient. But for alertness, you have to look for the alertness as well. If your patient is not alert, after the injection of those tablets, you need to start the acetylcysteine infusion. Okay, let's move to other question. Child with History of 3 months of intermittent cough and wheeze. Mother said it was started after playing. No improvement with asthma medications or antibiotics that were given. What is the appropriate next investigation? So what's the diagnosis there? What is the diagnosis? Nothing mentioned about fever. Please make your habit always first make diagnosis. Then it would be like very easy for you to answer the regarding if asked for the investigation or management. If you are sure of your diagnosis, you can easily then answer about that, like your question. Okay, some are saying bronchiolitis, exercise-induced asthma. Good. Someone answered it correctly. Dr. Good. Yes, it's foreign body. Always think of foreign body with the children who have intermittent cough and wheeze. It would be more clear if they mentioned unilateral wheeze. It would be more easy to diagnose them. But still, if they give you this unilateral thing, it would be more easy to diagnose. This is the case of foreign body, because some foreign bodies that are very, very small, they can stuck and they can remain there, and like baby will be symptomatic with a few. If the foreign body is large enough that they obstruct the flow of oxygen or they just block that passage, then it will be highly symptomatic. So we have a one guideline from the RCH. Just have a look. Okay, this is important guideline, so you need to go through this guideline in a detail. But now we just, because it's and we are just here dealing with inhalational, but there is an ingestional also. So you need to go through ingestional as well. That is the foreign body ingestion. You need to go through that as well. But here we are concerned with this point, inhalational. Okay, we will not discuss the life-threatening situation right now. So with the history examination, the first thing is the investigation. Okay, the first investigation, first and very foremost investigation is the chest X-ray with inspiratory and expiratory films along with the lateral decubitus view. Okay, sometimes X-ray comes normal because of the radial, if the foreign body is radiolucent. So normal chest X-ray does not exclude foreign body. If you are highly clinically suspicious of having foreign body, then you need to go through the bronchoscopy or laryngoscopy, okay? But still, the first line thing that you have to do, that you need to do, is the chest X-ray to check for the radiopaque foreign bodies, segmental or lobar collapse, hyperinflation, if there is any mediastinal shift, is there is consolidation that could be suggestive of pneumonia, because if it's a long-standing foreign body, it can lead to give the symptoms of pneumonia as well, even pneumothorax if it penetrates. So CT scan is never recommended, okay, but bronchoscopy might be required or laryngoscopy. So this is very important guideline. I would recommend everyone of you who have exam nearby, please go through inhalational and ingestional both. The other one is this foreign body ingestion, because we have battery button and all these things. What are the, like, we have high risk foreign bodies, and what is the time frame to deal with those foreign bodies? That is very well explained in these guidelines. Those who are enrolled students will go through these guidelines in our pediatric topic. I have attached this reference. Okay, the next question is, husband brought 70-year-old wife with confusion and paranoid episodes and visual hallucinations at night for 2 days. No previous psychiatric history, but alcoholic. History of UTI and treating with ciprofloxacin for 3 days. On examination, patient was agitated and disoriented. What is the cause? Acute psychosis, delirium, dementia, or alcohol withdrawal? Good. Good. So this is UTI-associated delirium, and that is very common in elderly. Okay, but you make sure just have a look for the other causes of delirium as well. So the delirium itself is a mnemonic, like drugs, electrolyte abnormalities, certain lack of medication that patient was already taking, like any withdrawal symptoms because of that medication, infection like UTI, reduced sensorial input, intracranial pathology that might lead to this sort of delirium, urinary retention or fecal infection that again can cause MI and the pulmonary disease. So these delirium mnemonic is like itself a cause for the delirium. Okay, you need to differentiate between delirium and dementia. The delirium has sudden onset, but the dementia has an insidious one. Course is rapid and it's fluctuating, like when it's treating, it's normal. Again, it can flare up. It is slowly progressive. Levels of conscience more impaired with the fluctuation, but dementic patient, they are alert. Attention impaired definitely, but they have intact. Memory, just recent memory loss, but they have remote memory loss. Then their thought process disorganized because mind is in acute stage of problem, and they have improvised. While hallucination, often visual or tactile, that is the feature of delirium. But in dementia, that until and unless it became an advanced disease, until then there are no any sort of hallucination. Okay. And the most important thing, the delirium is reversible. Treat the underlying cause and it will be fine. But dementia is usually irreversible. Okay, Dr. Sunny, why not alcoholic withdrawal? Because here they have clearly pointing you towards one is the age. Okay, the one clue is the age. Elderly has whenever they mention you elderly with UTI, okay, elderly with UTI, then think of delirium associated UTI associated delirium. The other thing is that she has a history of alcohol, like she is alcoholic, but we know whether she had left it or not. We don't know about the withdrawal. How we will say that it's alcoholic withdrawal? We have the history that she is alcoholic. Okay. And they gave a clue, important clue, that there was a history of UTI that was treating with the Cipro for 3 days, and these symptoms come with this 2 days. So that's why it's pointing us more towards delirium. I hope you are clear now with this. Okay, so the next question is 8-year-old boy with multiple episodes of gum bleeding, bruises, also knee joint swelling was there. No past history or family history of any disorder. Lab platelet was 140. WBC is normal. PTIN are done and normal. Like PT, APTT, both are normal. What is the next investigation? Factor 8, von Willebrand assay, repeat full blood count in 3 months, bleeding time, platelet function. First of all, tell me what's your diagnosis there? Can be. No one think of von Willebrand disease? Hello everyone, am I audible? Okay. Okay, so many of you think it's ITP, some with hemophilia. Okay. Okay. But what if I say, okay, it can be hemophilia, it can be von Willebrand disease. Then anyone agrees? Okay. If we don't think anything, like we are not like reaching to the complete diagnosis, if we say differential diagnosis, what would be the initial or next test that will differentiate? Because we don't directly go with this factor 8 thing or the von Willebrand factor assessment. We have to, they have asked what the question they asked, next investigation. That's why I always ask you to please read carefully the last line, what they are asking. Okay. Yes, now you are right. Whenever they ask next thing, please go with this bleeding time. Okay, if you are not sure that it's a von Willebrand and you are confused between von Willebrand and hemophilia, still the next thing would be bleeding time. If it's normal, they will give you a clue about hemophilia. But still, if it's abnormal or prolonged, you can easily think of von Willebrand factor disease. Simple. Because in both the cases, factor 8 is deficient, and in both the cases, there is problem with the von Willebrand factor. That's why they have similar sort of sign and symptoms. Hemarthrosis frequent in hemophilia, but also present in the von Willebrand factor disease. But the family history is very important. Hemophilia, they will definitely give you family history positive. Here they mention no past history or family history of any disorder. Okay, von Willebrand factor, it's also hereditary. Family history is there, but not that much important as compared to the hemophilia. Sometimes there will be no family history of von Willebrand disease because von Willebrand disease has a different variants and different types. Depending on the type of that severity of that disease, we can diagnose it as mild, moderate, or severe one. Okay. See, we have first we have two main categories: inherited and acquired one. Okay. So the inherited has type 1, type 2, and type 3. Most common type, that is autosomal dominant. And in this, there is mild to moderate deficiency of von Willebrand and factor 8 as well. That's why they have similar sign and symptoms, the hemophilia and von Willebrand disease. Okay. Type 2, also autosomal dominant. There is not like deficiency, but there is a dysfunctional this we have factor. And in case of type 3, that is very less, but it is the autosomal recessive inheritance. And in this, there is complete absence of von Willebrand factor and factor 8. So please make sure you go through these types and everything because it is very important. Okay, if we do some like investigations for the von Willebrand factor disease, the first and foremost is that bleeding time. And it will give us a differentiation because bleeding time will be normal in case of hemophilia. Okay. In hemophilia, FPTT is usually prolonged. But in von Willebrand factor disease, it can be normal or it can be increased, but usually it is normal. Okay. PT and platelet count remains normal in both. Yes, there will be decreased factor 8 and definitely there will be decreased von Willebrand factor antigen level. So please make sure you go through these things. Those who are enrolled students, they will like go through the lectures of blood disorders. So you can easily understand the concept of all these things. So moving on to the next question. There was a pregnant lady who signed not for epidural during the delivery. During labor, now she's asking for epidural, but the husband and nurse refused, saying in delivery plan it is signed no for painkillers. She is in distress. Now what to do? Give her epidural, discuss with the patient, refer to senior, follow the pregnancy plan. Everyone please answer. So most of you answered A, some of answered A, and most of you answered B. Both are correct, by the way. Now we have to see what we need to choose in which situation. So most of you are with patient autonomy. Okay, patient is in distress. Now what you will do? You will discuss or give. Because previously patient has refused for the epidural. will give, definitely, because we will consider it as implied consent. Whenever your patient is in that much pain and distress, consider it as implied consent. Okay. The best in this scenario is give her epidural. But if in scenario something mentioned like that, like they give you some clues regarding that she is forced for having epidural, in that case, best thing is to do discuss with the patient. Okay, next and best. If in the scenario there will be some clue regarding that someone is going to like forcing the patient. If they give you some clues regarding that, only then you can select this, discuss with the patient. Otherwise, best is give epidural with the help of this, like we have this implied consent. We can apply this implied consent in this scenario. Okay. Moving to the other question. 21-year-old girl with history of smoking and alcohol use is seen in the clinic. What routine investigation should be included in her health assessment? Blood pressure, lipid profile, liver function test, cervical cancer screening, carotid artery ultrasound. Please, everyone, answer. Yes, most of you are correct. Blood pressure measurement started at the age of 18 years and onwards. Lipid profile we do from the 40 years, 45 years and onwards. Cervical cancer screening is 25 years and onwards. Okay. Rest are not like routine screening, they are disease specific screening. So these are the routine screenings: BP, lipids, and cervical cancer, but the ages are different. Here they gave you like risk factor, one the girl, other is the smoking. So these are the risk factor for both the cervical cancer as well as the hypertension. So in that case, we need to see the age of the patient. The patient is 21-year-old. Nothing fixed other than blood pressure measurement because it started at the 18 years. Cervical screening, we start at 25 years. So the reference is from the Red Book, 10th edition. For the screening and the cancer guidelines, you need to go through this. So screening for hypertension in general population from 18 years is recommended. Okay. But we need to exclude the white coat hypertension as well. And if there are secondary causes, then that should be excluded. So we have next question. The question was about a lady who had meconium stent liquor, but CTG was okay. Then she was transferred to the tertiary hospital. She also felt decreased fetal movement. Initially, fetal heart sounds was 90. Upon arrival, no fetal heart sound or heart rate heard. Cervical dilatation was 8 centimeter. What to do? What you will do in this scenario? Ventrous assisted delivery, cesarean section, repeat CTG or ultrasound? So, yes, exactly. First, we need to confirm the fetal demise. Okay, we need a documented proof that when patient arrived, the fetus was alive or not. We were not able to hear the fetal heart sound. We might be wrong, but once we are suspicious that patient has risk factors. How many risk factors? He has mechanism like us. He was referred. Definitely, there was some problem. That's why he was referred. And there was a complaint of decreased fetal movement. Initially, 90 hertz, then again heard with no fetal heart sound. We need to confirm. Now, delivery is not the imminent thing. We have to deliver the patient in any way, but we have to confirm whether the baby is alive or not. If baby is not alive, we need a documented proof with us. Okay, so here, ultrasound. We need to confirm that and then we will decide accordingly. This is from SAHL, but one from RSCGP is more easier to understand. So let's discuss this. So here, if this our patient was in labor and there was a mequinemic liker and all these things, but just go through the topic with this, like if the patient is presenting with the decreased fetal movement, okay, and the gestation is more than 28 weeks. It should be more than 28 weeks when they present with this complaint. Okay, we have to take the whole history and examination. We need to rule out the risk factor for fetal death and IUGR. Okay, so that's why history and examination is important. Once history confirms that it is decreased fetal movement, okay, we need to examine and auscultate the fetal heart rate for viability. Referral in our question already done. Fetal heart rate detected, then we have to start the CTG. We need to start CTG to see whether CTG is going well or not. The CTG is again a very big topic we will discuss in our obstetric class. Till then, if it's a normal CTG, we reassure the patient there is no need for further investigation. He can easily go home. But if fetal heart not detected, what would be your next step? Like in our question, we need to do immediate ultrasound to diagnose or exclude intrauterine fetal death. Okay? If we are confirmed with IUFD, then we have to manage it as we have to deliver and all these things, all the protocols of IUFD and all these things. But if it's not, then CTG, we have to look for the CTG again. What is CTG showing? We have to respond that situation in that way. CTG abnormal, we have to manage clinically. If indicated, we need to deliver. Okay. So this is very important step that once you are you are unable to detect the fetal heart rate, please someone who had marked on the screen just remove it. Otherwise, it will be shown to the question as well. Google Pixel. Because I can't erase the one you have marked. Thank you. So our scenario was our patient was here when fetal heart rate not detected. In that case, we don't opt for CTG. We don't rush for delivery. We have to confirm the diagnosis of intrauterine fetal death. Okay. Now this question. 80-year-old patient sent to emergency department from aged care because she was agitated and not eating at all. On physical examination, there was all over bruises, both her hands and abdominal area. Otherwise, she was attentive, answering your questions with care now. Her vitals and lab values were normal. What could be the reason for bruises? So with this scenario, what you are expecting is that elder abuse, some sort of neglect, or physical restraint? So most of you answer it as elderly abuse. Okay, some says neglect. So most of you are with elderly abuse. Yes, this is one of the most important differential. Okay, see, she was agitated, not eating at all. Physical examination, there were all over bruises. Both her hands and abdominal area, exposed areas. Okay, these are exposed areas. Anyone can see easily. Otherwise, she was attentive, answering your questions with care now. Initially, she was agitated and all these things, but now she is answering your questions very well. Like she has a good eye contact with you. Her vitals and lab values. These lab values are important, which are all were normal. So neglect has been like it's excluded. Because if there would be because of neglect, there will be certain nutritional, certain vitamins, certain deficiencies, certain electrolyte imbalances that will indicate that there was a neglect, patient was not taken care properly, or the medications were not given properly. But labs are normal, just explain. Okay, I have told you when you don't know the answer, just start with the exclusion method. Okay, so this is excluded because labs normal. Now we have two important differentials because this is very important, the elderly abuse. But there's a thin line between this physical restraint and elderly abuse. See, when they mention the exposed areas, because when patient is agitated and he's hyper or he or she is hyper, what you will do? You hold the patient from hands or either from the back with from the abdominal area. That might lead to bruises as well. Okay. If it would be on elderly abuse, the bruises most probably would be hidden areas like inner arm, thigh, okay, upper thighs. Can't it be? So, and with elderly abuse, the patient will not be normal. Like he or she won't behave normally. They will be depressed. They will be like not very attentive. But if after correcting, after admitting, after giving medication, after addressing the agitation, they are normal, think of physical restraint. That's how they confuse you with the different scenarios. Everyone is clear with this? Because these ethics sort of questions and all these questions, they are like bit tricky. You need to be very attentive and focused while solving these questions. Dr. Asif, what you want me to repeat? Okay, the concept. So I was telling you, if you are not sure of the answer, like in mostly in ethics question, we are not 100% sure. It's not like a crisp and clear thing, like a theory that if you do this, this is the pathophysiology. If you do this is the disease, you go with this investigation. If that comes in that way, what will be your management? So ethics are a bit different. So you have to be very much clear about your like ethically. You have to be think in every aspect. Okay, the patient presented with agitation and there was not eating at all because he became agitated. What could be the reason? Whatever could be the reason. Okay, but when as a like intern or GP you did examination, there was bruises all over the both upper hand and abdominal area. Now look at the areas where they have mentioned about the bruises, hand and abdominal area. Okay. Otherwise, she was attentive, answering your questions with care now. Like you have given all the care and you the patient became easy with you. Now she is giving you all the answers very clearly and attentively. Vitals were normal, lab values were normal. It's okay, no worries. So in that case, if labs like if there will be a case of neglect at the aged care facility, what happened? There will be some disturbance in the lab, like there will be some nutritional deficiencies, some electrolyte imbalances. So that could be evident from the this lab values. So neglect at the healthcare facility, it is excluded. Now we have two things: the elderly abuse and the physical restraints. So if it's a case of abuse, they will give you some more clues about that. The patient is depressed, patient not cooperative, or patient not giving you questions clearly, answer clearly, or she has not a good eye contact with you, or there will be the bruises would be on inner arm or upper thighs. Okay, those areas which are not very exposed. So in that case, think of now we are left with this physical restraint because during restraining, what happened? We hold the arms of the patient. We hold from the back, so the our arms are like swinging around the abdominal area or the upper chest area. So that's why just consider it as physical restraint. We have a reference from RSCGP. No worries at all. So if there is a physical abuse or elderly abuse, they are being afraid of many persons. Okay, they will remain irritable and easily upset. They are not alert, they are anxious. They will be depressed and apathic. Okay. There will be skin traumas. There will be bruising, skin tears, burns, bed sores, ulcers. Okay. The our reference is this. There will be signs of restraint. When are the signs of restraint at wrist or waist, the abdominal area. Okay. So just go through this PDF in your own time when we upload on the website. Just for the one you can read it and you will get the concept in very much detail. Okay, last question for tonight. A 28-year-old lady came with dysmenorrhea with regular cycle. She's on OCP. Pain not improved and patient want to get pregnant in next 12 to 18 months. What is the next management? Please be attentive. This is the last question. Everyone, please, I want you to answer. Okay, some with B, D, A, B, mixed answers. Okay, let's exclude. Patient with dysmenorrhea, most probably primary dysmenorrhea, because there is no any underlying pathology they have mentioned about. They have not pointed us towards any underlying pathology like endometriosis, PID, or anything else like that. So it's a more probably primary dysmenorrhea. Cycles are regular because she's already on OCPs. Pain not improved. Okay. OCPs are actually like when stop now. Okay, Jessica, I'm explaining. Just be patient. I'm explaining. Okay. So she's already on OCPs, and besides on being OCPs, the pain is there. Pain is not resolved. Sometimes in dysmenorrhea, what happens? We give hormonal treatment, so OCPs can be given, but it's not the first line. The first line is always the non-hormonal treatment. Might be she was taking OCPs for some other reason. Might be because of contraception. Might be because of PCOD she might have, and she for the regulation of cycle she's taking OCPs. But still the pain is not improved, and she want to get pregnant. They have given you the one clue that she wants pregnancy in next 12 to 18 months. Okay, it's 12 to 18 months, like 1.5 years. Not now. Continue OCPs. Yes, sure, we can continue. But what about the pain? Pain is not resolving. So this option gone. We will continue, but for pain, we have to do something. Okay. Stop OCP and add naproxen can be an option. But the thing, she want to be pregnant after 12 to 18 months, not now. If she stop OCP, she might get pregnant. Okay. So this option excluded. Depo-Provera. If she is using first, this is not the first line thing. They ask the next management. Depo-Provera never be the first line for the management of dysmenorrhea. And with this, fertility delayed. And they gave the clue that she wanted to be being pregnant in 12 to 18 months. So we are left with mefenamic acid. So NSAID actually are the first line drugs for the dysmenorrhea. So NSAID can be mefenamic, ibuprofen, or it can be naproxen as well. Everyone clear? Just look at the reference. This is from the therapeutic guidelines. Hormonal treatment is COCP that she was already taking. Okay, LARC can be given, but it's not in our scenario because our patient want to be pregnant in 12 to 18 months. So the first line for the dysmenorrhea are the NSAID. Can be ibuprofen, can be mefenamic acid, can be naproxen. Now you clear why we didn't choose naproxen there in our scenario? Because our patient, because that was with OCP, that is stop OCP, and we can't stop OCP. Otherwise, she will get pregnant in meantime. So that's why we didn't choose naproxen there. Then we went left with this option. When you are not sure with your answer, please do exclusion method. You will be like more clear about your answer. So thank you so much, everyone. This was from my side. This was the last class of pre-call session. If you have any questions, I'll be happy to answer. It's not like Dr. Hassan, 100% accurate, like you stop OCP and you get pregnant on the next day. It can take one cycle, it can take two cycles, but it's not like with the OCPs that fertility is delayed. Once some like leave OCP, they can get pregnant in their next cycle. So that's why here we don't choose this stopping OCP. Dr. Abdul Manan, we are launching our crash course for the recalls. Yes, recorded lectures are of all subjects are available for the enrolled students. And we have our website. All students who are enrolled, they have their portals. They sign in, they log in with their portals. And when we have started till now, everything is uploaded there. Even these recall classes is being uploaded there. Dr. Hassan, for recalls, the theory course which we have started, it's for the 4 to 5 months, while this recall classes can be of 2 to 3 months because it's a crash course. And in those classes, we need to be very quick, like we need to solve a lot of recalls in this 2 hour time. Yes, Dr. Manan, any crash test system? Sorry. Yeah, we have our mock test for our enrolled students. Whenever we go through any subject, like for example, we have covered CBS, then we have a mock test for the CBS after 1 year. Okay. Yes, Dr. Sunny, all the things are recorded and these are being uploaded at the website. Mhm. I think you all are in the group, the recalls group. If you are in that group, every information will be uploaded there. How to join, when to join, what would be the course fees and everything. And when we are going to start the dates and all the schedules. Dr. Manan, okay, you are not in the group. Let me see. Okay, use and contact these numbers. I'm just sharing these 2 numbers. Okay, those who are not in the group, kindly contact this number. Dr. Everything will be explained there. And the theory course we have already started from the month of August. Initially, we did free trial classes for 2 weeks, like we are doing for the recall. But now our paid students are there. Yeah, sure, Dr. Jessica. Thank you so much for joining. Tomorrow will be the last class. Please, I request all of you to join that class as well. Okay. So Dr. Anis has shared all this information. Thank you, Dr. MP. Yeah, the link someone had shared, all link and everything, every detail. Dr. Awais Asif has shared everything. Please, who are new to the group or who are not aware of our group, go through this and join the WhatsApp group. Any other questions? Because it was last class, that's why I just want to take your questions and queries. That's why I just ended it early. so much, Dr. Isma. Thank you, Dr. Nadia. Thank you, Dr. Manan. Thank you, Dr. Awais. So if there are no any questions, then we can end our meeting. And we will meet if you guys enrolled. We'll meet in our sessions, or if you guys enrolled in our theory classes. Most of theory we have covered. Those who are interested, they can enroll even now. The recorded sessions are available. Still, we are like, we have a lot of subjects to cover. Okay, everyone. Thank you so much. Thank you so much for attending the class, and thank you so much for having faith in us. Take care. Bye bye.